Hepatitis E is another one of those extremely common but almost forgotten viruses. It's an afterthought for many when thinking about a patient with hepatitis. Yet the World Health Organization suggests that there are 20 million new incident cases per year. About 3.8 million of those are symptomatic. I have no disclosures relevant to this presentation. So what is it? It's an enterically transmitted zoonotic RNA virus. There's 4 primary genotypes capable of human infection, though recently we have reason to believe at least 6 will infect humans, maybe 7 or 8. And there's at least 7 or more total genotypes. As we look through the animal kingdom, we find new, unique forms. We see that here and how they're distributed. The zoonotic form is primarily genotype 3 and has been primarily associated with transmission from swine, but a number of other species have been implicated as well. You could see that it's quite a wide range. There's been several reports of transmission from camels of late in a different genotype. I'll show you some information about rabbit transmission in just a second. This was a report that came from Abbott Laboratories, presented at AASLD a few weeks ago, showing a demonstration of transmission of 3 acute cases in France, 2 of them associated with wild boar, 1 of them from a rabbit. So the first really clearly documented case with a transmission from a rabbit that is not within the other genotypes. The overall distribution of genotypes is shown here. You can see in the United States there's a hot spot in the Midwest where my lab is, and we're not exactly sure why that is, though we suspect increased exposure to farm animals is a big factor in that. The initial immune response to hepatitis E appears to be primarily an innate response driven through interferon-stimulated gene response, which leads to clearance in the majority of immunocompetent patients. However, those that are less than immunocompetent have a blunted response, which may lead to an alteration in the clinical presentation and lead to development of chronic disease. Diagnostics are part of our problem. They are not ready for prime time, unfortunately. I'll take you through that, and we'll start with a clinical case. This is a 45 or 46-year-old woman who had biopsy-proven PBC with a possible autoimmune overlap. She was AMA positive and anti-actin positive, and in 2013 on a liver biopsy had F2 fibrosis. She was treated with urso at 13 milligrams per kilogram. However, she increased her LFTs, including alphos and ALT, in recent months. A FibroScan on should have been December 30th, 16, suggested the presence of cirrhosis, as did the ultrasound. She was started on obeticholic acid, but 6 days later said she's just not feeling well, and we brought her in. She was clearly jaundiced, severely fatigued, epigastric discomfort. We held the obeticholic acid. We sent off a variety of tests. The Hep E IgM from an outside lab 5 days later came back positive. I got a frantic call from her primary care physician saying, "What is this and what are we going to do now?" We'll come back to that. So the tests for hepatitis E are summarized here. There is hepatitis E, IgM, and IgG. There has been some effort in various places to develop serotyping assays, and there is an HEV ELISpot assay. Virologic testing from serum and plasma or from stool includes PCR-based testing as well as HEV antigen tests. The typical course is shown here. We begin to see evidence of virus in sera within about 4 weeks, but shedding in stool starts before that. We see peak ALTs in the midpoint of the virus in the serum with symptoms appearing late, in fact, as the ALT is beginning to drop. IgM comes up first, followed by IgG, as you would expect. In a subset of patients, there is a continuation to a chronic disease state where patients either continuously or intermittently shed virus in stool, and intermittently or continuously can be detected in serum. The serologic assays, both IgG and IgM, are available from a variety of manufacturers. There is low confidence with some or most of the assays. None are approved in the US. Here's a summary of some of the major IgM assays. We've tested most of these in my laboratory. Again, as you can see, none are FDA approved. The antigen is slightly different, as is the assay methodology for some of these. There's been a number of studies in the last 5 years looking at assay comparisons. This is a recently published one doing a comparison of a series of different tests. They all detected, but looking either sample from a patient, a genotype 3, or a WHO genotype 1 reference, there's some variation in the detection limit. And here's another example of 2 tests, the adultus test and one-tie test, with 100% sensitivity in a panel, but only about 80 to 85% specificity, which does lead to a problem with false positive reactions. I've had the opportunity to, over the last few years, under the auspices of R01 from NIDDK, to look at several cohorts, including the NIH solid organ transplant cohort. We presented some data at AASLD a few weeks ago, and it brought up another interesting issue in that many of these patients actually underwent seroreversion. Proven positive patients by more than one assay became negative. You could see that fairly high rates of seroreversion seen in both liver and kidney recipients, which was associated with them getting immunosuppressants following transplantation. So it suggests that these patients may in fact be more susceptible to reinfection following transplantation, and certainly takes away from our ability to do that testing and determine if these patients even have antibody present or not. Our laboratory developed an ELISpot assay, and we use this as well as a way to confirm positive infections, looking for evidence of interferon gamma response. So virologic testing is complicated by the fact that there's a very short window of viremia present in most patients with an acute disease process. This can be as short as 2 to 3 days, in some patients as long as 2 weeks, but again, you've already through most of that window by the time a patient comes to clinical care. Shedding is longer in stool, but the testing is generally not available. This is our in-house assay, just to give you an example, detection of a standard down to 10 copies and a clinical sample showing a positive versus a control in yellow at the bottom. So we can easily test this to a very high degree of sensitivity using real-time PCR. There's also antigen test assays which have been developed. They are not easily available in the United States, but are available in Europe from a commercial laboratory. and appear to be effective across all genotypes. Several years ago, I proposed a diagnostic criteria. We've been applying these diagnostic criteria in samples that have been sent to my laboratory for confirmatory testing. We suggest that you cannot make a determination of an acute disease process with a single test. You either need to use two different IgM reactions or detect HEV RNA, or look for evidence of a rising titer, the convalescent titer increase, or use the interferon gamma ELISpot as a confirmatory test. And then chronic HEV is detection over a 6-month period in stool or blood. So the case I presented to you, we tried to determine what assay was performed in the commercial laboratory. They said they didn't know. It was a proprietary assay, and they would not tell us anything more about it. So we did our own repeat testing on that sample using the Wantai assay. It was negative. We tested for HEV RNA, and it was negative. We looked for HEV and collected both acute and convalescent titers, and that is shown here. This was the initial, which was positive in the intermediate zone, but over time, clearly negative 2 weeks later sample. So this is a patient that by 3 different measures we call a false positive, and you could see how easily we could have been misled based upon the clinical presentation and the initial lab result. The clinical outcomes that we see vary by the classification of the patient. Immunocompetent patients get acute disease. They do not appear to develop chronic disease, and mortality overall is very, very low. In people who are pregnant and get infected, they get acute disease. They do not appear to get chronic disease. The mortality is variable depending on where in the world you are. We'll talk some more about that in a few moments. For those with chronic liver disease, we see acute on chronic presentations. These patients don't seem to develop chronic disease, but they have very high rates of mortality. And then in immunosuppressed patients, those with HIV post-transplant and those undergoing cancer chemotherapy, there is acute disease with progression to chronic disease and variable rates of mortality. It's been suggested in several studies that HEV is an immune trigger for Guillain-Barré as well, and we have been trying to put together a cohort to examine that in the US. This is a look at a study on chronic decompensation, a group of patients with known stable cirrhosis in India. A subset decompensated. They were compared to a matched group that had stable cirrhosis, and as you can see, there was a very high rate of acute hepatitis E, suggesting that that was the source of the decompensation in those patients. Here's another example, a patient with a liver biopsy done, submassive necrosis, and a patient with cryptogenic cirrhosis. It was associated with eating shellfish and or pork because the patient ate both and they couldn't track down the exact source. Studies in the US have looked at acute on chronic in the HALT-C cohort. The odds ratio compared to controls of having acute Hep E was 2.1, but that was not statistically significant, and there was no overall difference in overall IgG prevalence. So this appears to be, in those with chronic disease, a relatively rare issue in the US. These are patients presenting de novo with acute liver failure. This study in Germany, 10% of acute liver failure presenting to University Hospital in Essen were ultimately attributed to acute HEV. However, the initial etiologic diagnosis was wrong in all cases. And in the US, in the acute liver failure study group, report starting with a large number of patients, followed down for further evaluation for HEV. 3 positives confirmed, and they concluded that this was not an important factor in acute liver failure. However, there were 18 patients that had indeterminate test results, and if even half of those had actually been real positives, because they did not undergo the type of testing that I showed you a few minutes ago, the conclusion of this study would have indeed been different. In pregnancy, maternal mortality is as high as 25% in some places. There's a very recent outbreak this past summer in Niger and Nigeria. Low mortality has been reported in other places. The reason remains unclear. Differences in genotype could be a factor. The outbreak in Niger and Chad and Nigeria is a genotype 2 outbreak. The epidemiology of exposure is different in different places with different ages of typical initial exposure and presence of antibody that's pre-existing before pregnancy. Host factors could be a factor, and there is a study suggesting that lower NK counts during pregnancy may contribute to more severe outcomes. It's also been suggested that poor maternal health and birth care may be important factors in high rates of mortality in parts of the world. We also see acute to chronic disease, as I said, in HIV, organ transplantation, and chemotherapy. This was first reported by Dalton with a series of cases in the United Kingdom, virus present over an extended period of time, several years. This has been shown to progress to cryptogenic cirrhosis. In transplant recipients, similar studies showing either high peaking levels of ALT followed by chronicity, or rather indolent levels of ALT. Here's a patient who had evidence of inflammation. It was misattributed to acute rejection post-transplant. The patient rapidly progressed in 150 days to develop ascites with cirrhosis, and later the donor was identified as the source. Management, there is inhibition with pegylated interferon, ribavirin, and some effect of withdrawal of immunosuppression in about a third of patients. Ribavirin for 12 weeks leads to fairly high rates of clearance, but persistent clearance, SVR, in about 70 to 75% of patients. This is a little bit busy, but it's an algorithm that defines the long-term management of the chronic patients, including initial treatment with ribavirin, follow-up testing, which you then decide whether to continue for another 12 weeks or longer if the virus remains positive. If the virus is negative, then the patients are given a second course if there's recurrent disease, and then you just follow them to look for management of advanced liver disease, expecting rapid progression. In conclusion, HEV is prevalent in Western countries where it was previously unsuspected. It's underdiagnosed due to low clinical suspicion, poor assays, low availability of those assays. There is a low risk of chronicity overall, but when it occurs, it could be associated with progressive liver disease. And keep in mind that chronic HEV, if you can identify it, is largely a treatable disease. I'd like to thank my collaborators and appreciate the opportunity to speak today. Thank you.